Hi, everybody. This is Susan Clinton, one of your hosts for Tough to Treat. This is episode number 205. In this episode, it's a short podcast for me discussing some examination and interventions for GI dysfunction. I hope you find some of the novel approaches interesting, and I would certainly love to hear your feedback on this. Enjoy the podcast. Thank you. So physical therapy intervention, we need to really treat bowel dysfunction and abdominal pain like peeling an onion, one layer at a time. We want to pay attention to the body, treat the primary motion restrictions first, and then move on to the specific issues. Just starting off very regionally in the perianal region is often going to be limiting to the outcome potential. As we look at intervention, we're going to talk about spinal. So the spinal motion restrictions at the thoracolumbar junction, the lumbar sacral junction, the sacrococcygeal, and how that affects the whole patient and their ability to move, stand, rotate, and change positions. We want to find hypomobile segments and kind of decide if it's really a hypomobile segment or if it's a muscle spasm, muscle holding, if it's somatic versus viscerogenic, or if it's hypermobile, moving too much and a little bit irritable. We want to look at oscillations of the SC joint to see if we can reduce the pain and the tone around the perianal region. At various levels, does this patient need more spinal movement or more spinal motor control? What is it that they need? How do they function in all of those different kinds of functional mobilities of standing, walking, cross pattern, weight shift, ability to stand on one leg, move arms and shoulders without restrictions. And finally, rotation, rotation, rotation. Restore rotation as much as you can to the spinal area. It's going to have very, very wide effects on the rest of the GI system, the abdomen, and the pelvic region. Moving on, we want to also pay attention to the hip joint and below. We all know that the obturator internus and the relationship to the pudendal nerve is a big one, and we want to look at that for sure, but we also want to kind of pay a little bit closer attention to the coccygeus and the transverse peronei mobility and activation, as that's one of the biggest restrictors of movement of the EAS. If that EAS can't descend down with the tissues, it's going to be hard to be able to push a stool through. We also want to look at, are they actually in positions where they're getting their glute max, medes, and minimums to work at really good quality, or are they standing in ways where they're just kind of leaning on their ligaments and their muscles just aren't firing? Myofascial and mobility are big things to look at as well. We want to treat the obvious restriction first, as I said before, and move from the transverse diaphragms all the way up and then down to the thighs. So we want to think about where can we get the best bang for our buck that's going to give us the most rotation within the system. And that's going to be really working the myofascial mobility of the transverse diaphragms. We want everything to slide and glide together. And then we can go inside and maybe treat any kind of restrictions that we may find inside the pelvis, or how can we have an effect on the entire autonomic system by just getting big, nice rocking movements going in the whole body. Visceral manipulation is probably a term that's unfortunately used like that because most people are like, I don't manipulate viscera. And it's like, we're not. When you're dealing with and pushing along organs through the abdominal wall, you're really just messing with neurology. That's all you're doing. It's response to touch. So we can have touch that we can use and specific motions that we can do that can help actually move the visceral organs in a way that the diaphragm does all day long, every day, 16 times a minute, or 8 times a minute, however much anybody's breathing. So we're not really doing anything more than that. We're certainly working on the abdominal wall. We're not even pushing the abdominal wall around as much as people are when they're sitting and rolling in bed and moving in and out of chairs and lifting and carrying things. So we look at the fascial structures of the abdomen for sure. In the colon, we look at the ileocecal valve and the descending colon, and there's some ways that you can actually move those and get some better function there. The small intestines through the mesenteric root, and epigastric traction to help people overcome gastric reflux while they're trying to get off of their proton pump inhibitors. Our manual therapy interventions continue here with cervical, thoracic, and postural considerations of the forward head posture. If we've got somebody who's got a really strong, dominant forward head posture, that affects their ability to chew and swallow. It affects the ability of the thorax to hold the head, just the head being held on the shoulders, And it also affects how the thorax might be getting pretty stiff because it's having to balance that head in front of it, as well as the visceral cavity from below. Rotational quadrant movements and head rotation for rib mobility at the rib heads were really very, very helpful in getting thoracic mobility restored. Finally, we want to just think about some things around us, the abdominal massage. One thing that it has been shown to do is to maybe help with slow transit constipation. It's a theory, but it's been hypothesized to increase the peristalsis of the colon. Documented as early as 1870, there have been many studies and talks about doing the abdominal massage to make your bowels work better. One study looked at the abdominal wall massage 3 times a week for 3 weeks. Another study looked at that same thing and found out that it didn't really improve slow transit constipation, but it may have made people feel better to rub their belly. So that's a quality of life issue. Maybe it's still slow going through the colon, but they're not as crampy and painful when they do an abdominal massage. Later studies used daily massage over longer periods in their studies. In 1999, they reviewed 4 small clinical trials. All studies were very small and only 2 were controlled. But massage and connective tissue manipulation improved symptoms. They didn't really find any statistical differences in BMs with massage versus laxatives. Elderly people massaged 12 weeks significantly had frequency of BMs, so that's a good thing. And children with physical disability that had the massages for 8 to 10 weeks had a 42% increase in BM frequency in 50% of the clients. So there's something to it. Not sure exactly what the mechanism is. And again, I think it's because we're just moving the neurological system around and changing the way that it's feeling and giving some variance around that system, because the GI system is designed to move. So if for whatever reason these adults and children aren't moving because of disease or disability, then the massage can be a beautiful thing for them. We also looked at daily massage to decrease constipation in a 21-year-old spastic CP in one study. She did it for 12 to 20 minutes daily, and she went up, across, and down, just kind of following the path of the colon. And for her, she had spontaneous bowel movements a half an hour following massage and was able to get off of her enemas. So that's pretty good there. You don't have to use your hands. You can use a tennis ball to provide circular movements on patients with disabilities. In this one study, they actually followed the path of the colon 10 minutes a day and rolled a tennis ball around easily on their tummies and had increased bowel movements. And patients in a hospice setting with 10-minute massage along the colon path had a decrease of abdominal distension and flatulence. And so that's really kind of a nice thing, especially when you have people in the passive care of hospice. So contraindications for the abdominal massage. Well, if they have a known or suspected abdominal obstruction or GI obstruction or bowel obstruction, no, we're not going to do that. If there's an abdominal mass there and you don't know what it is and nobody knows what it is, they need to go to the physician's office and find out what's happening. So you're just not going to go in and start rubbing that. And then, if they've had abdominal surgery or radiation within the preceding 6 weeks, everything needs to heal first. Let it heal. Then you can start with scar work and abdominal massage after that time. Patients with chronic slow constipation, if you want to think about how the abdominal massage can work, I want you to think about what might happen with it if you just were thinking about moving neurology. The whole idea here is to get them to feel better and to get them to be a little bit kinder to themselves. And when we start doing an abdominal massage on a slow transit constipation person, they generally have some sort of abdominal pain or discomfort anyway, and it really does help with that. And oftentimes when you can quiet the system, then you can actually produce bowel movements. You may not be changing the transit, but you are changing the neurology around it so that they feel more comfortable and can move their bowels with greater ease. So let's move on more with the physical therapy examination intervention of the abdomen. So one of the things we want to do is look at the whole person and not really be as regional specific, because there could be drivers coming from other areas. So we want to look at posture. Are they ligament leaning? Are they stooped? One of the things that I look for is not as if it's a bad or a good posture, but what's the dominant posture? Because it's the dominant posture that we probably need to change. And it's not so much changing it, but giving them variance around that dominant posture. And what happens when we do change the posture? Does it change their symptoms in any way? Are they worse when we actually load them in postural standing or postural sitting? Want to definitely do a neuroscan. We just talked about that and the importance of that. Upper motor neuron, lower motor neuron. If we're looking at lower motor neuron, we're looking at spinal stenosis in the lumbar spine, radiculopathy, neural compression versus inflammation, so posterior lateral nerve roots, things like that. That can be part of what's going on. Spinal motion is important to just look at flexion, extension, side bending in the lumbar spine and the thoracic spine, add in the rotation. One of the things that I think is really helpful is looking at thoracolumbar junction, area of counter rotation between the lumbar spine and the thoracic spine. Remember, T11 through L2 is where a lot of neurology for the visceral organs come from, particularly in the GI system. We want to, next slide, we want to continue on with general strength, core muscle activation. Can they turn those muscles on? Can they bring them on when they need them to come on? Do they happen automatically? Are they overcooking their abs by really pulling their abdominal tone in really hard, becoming abdominal grippers? What kind of myofascial restrictions do they have? Do they have restrictions in their abdominal wall? Do they have restrictions in and around, organ mobility? Is the abdominal tone hard or is it soft? Do they have pain, tender points? Is the Carnett sign positive for visceral pain or for abdominal wall pain? Careful examination of the abdomen, perineum, and the anorectal region is very important. So you want to put all that together as you're looking at the pelvic region that we did before. In the abdomen, you're going to palpate for stool, hard restricted tissues, scar tissue, pliability, mobility, and motility of the viscera. The perineum, you're going to be looking at visual for patulous anuses, scars, skin, excoriation, prolapsing hemorrhoids, skin tags, or fissure, just like we talked about before. When we're looking at the respiratory, we're going to be looking at, does the diaphragm move? Do they have basilar rib motion? What's happening there? What does their breathing look like at rest? What does it look like when they're exerting a little bit more? Remember, with primary respiratory muscles, the diaphragm is the one, and its job is to increase the negative pressures in the chest to draw the air in by descending, and then it returns the airflow out. And the other important thing is the diaphragm with the abdominal muscles and pelvic floor work very hard to clear the airways for coughs and sneezes. We want the inspiration and expiration to just match the demands of the activity. Are they really breathing hard just sitting? Or are they really having to exert really hard to just get out of the chair or get off of bed? Why are they having to work so hard, and why are they breath holding or breathing so hard to do that? Phonation, what does it sound like from quiet talking to yelling really loud? Are they able to develop a very strong, loud voice, or does it start to crack and fade immediately? And remember that the diaphragm itself, too, is the primary mover of the internal organs. So if they're breath holding or not using, not breathing with all of their muscles up high and not really letting their diaphragm do the work of being the primary respiratory muscle because they're asking it to be a postural control muscle, we're not getting great movement of the internal organs like we should be getting. So we really want to keep that in mind, and that's why we really look at breathing and changes in breathing. This is just a picture to remind you that we have pump handle breathing and bucket handle breathing. So the pump handle breathing is the ribs coming up and down in the front, the high ribs, and the bucket handle is the ribs going out to the side and up and down as you see them move that way. Faulty breathing patterns, there are some consequences to that. We can get changes in the respiratory chemistry and in the pH levels in the body. So if we're breathing high and hard like we are exerting or running from the saber-toothed tiger, we're in definitely much more of an acidic state. And remember, the small intestine and the GI system like to work much more in an alkaline state. So when we're in an acidic state, that chemistry tells them to shut down. That it's not a good time for them to be working, that we need to have this other chemistry so that we can escape. So this is going to trigger smooth muscle constriction. That makes sense. We don't want the GI on when we're trying to survive. It changes electrolyte imbalance. It causes decreased tissue oxygenation over time, and then an increased excitability of the nervous system and the muscles. So some systems are not going to get the oxygen. The muscles and the nervous system are going to get super excited. So we get twitchy, and if we don't know how to turn that system off, we stay pretty twitchy. Musculoskeletal and fascial support is important to understand too, because we have to remember that the abdomen is in a visceral water balloon, so that all those organs are sitting inside that balloon. When we have problems with prolapse, and scar restrictions and myofascial restrictions, we want to also consider that musculoskeletal fascial support because it may not be working as optimally as possible. When we have surgery to the area, and that can even include C-sections, hysterectomies, gallbladders, endometriosis surgery, all of the above, and anything else too, colon resections, all kinds of things, all of those are going to have effects on how the abdominal wall and the abdominal cavity is going to heal and is going to move. So we want to also think about vaginal deliveries, lacerations, and episiotomies. It can have a great deal of dysfunction around the EAS if, unfortunately, they tear very deep. So consequences to surgery are going to be gastric paresis with any form of anesthesia in the early post-op stages. So the whole bowel tends to shut down under anesthesia. It should start back up, but on some people it doesn't. And so they get the big ileuses and the swelling and the things that go on. That's why early mobilization of people following surgery is super important. They want you up, they want you moving, they want everything going as much as they possibly can get going to get the bowels back on and the urinary system working. Another consequence to surgery can be small bowel obstruction, incontinence, and diarrhea because they've got catheters in, and sometimes if they deeply sedate people, sometimes they have trouble with their systems just switching back on in the right way. Another consequence of surgery, myofascial and visceral restrictions from surgical incisions. That makes sense, right? If they cut you open, they're going to have to stitch you back up. There could be decreased mobility of the entire abdominal wall and/or pelvic cavity, and decreased organ mobility and motility. And so oftentimes we'll find really deep scars on people or really thick scars. And it's always a conversation that I have mainly with physicians is they tell me that, you're not going to change that scar. And it's like, I know I'm not going to change the scar. I'm going to change the scar's ability to move in the body. Because what ends up happening is the scar becomes so adhered that the body begins to move around the scar. And that can really change motility and mobility of the entire GI system, as well as the rest of the visceral organs and the organs of the pelvic cavity. We also have a change in normal abdominal, pelvic, and thoracic cavity pressures when we have surgery. So when they cut you open, the abdomen is a low pressure area. When they sew it back up, there's kind of almost a pop that occurs when they open the abdominal visceral cavity. When they sew it back up, it takes time for those pressures to restore themselves. And so you're left with either a higher intra-abdominal pressure, in most cases, especially following C-section, or you're left with a higher thoracic cavity pressure, which really drives the intra-abdominal pressure of the abdominal wall as well. You're going to have breathing dysfunctions because it's not comfortable to allow your belly to expand and relax with breath. So oftentimes they'll shove the breathing up higher into their system and not to go down lower. That also changes and affects how the pelvic cavity works, because if we don't have good diaphragm descent, we're not going to get great pelvic floor descent and pelvic floor lift, because remember, the two go hand in hand together. Because of those pressure changes, that's going to affect the pelvic cavity as well as the abdominal cavity. One of the things that gets affected in the abdominal cavity is the colon, because the ascending and descending colon are retroperitoneal, and they have to overcome pressures in order for stool to move through. So if we have changes of pressure in the visceral cavity, that's going to greatly affect the GI system there. The sigmoid colon has to overcome the differences for evacuation into the rectum as the sigmoid passes from the abdominal cavity down into the pelvic cavity. We're going to have changes in the lumbothoracic and cervical range of motion and postural adaptations around any type of abdominal surgery. We're going to have changes in core muscle activation, coordination due to surgical trauma. And we're going to have changes in lumbar trunk stability due to the effects of abdominal tone on the thoracolumbar fascia. So if we have low tone, like the stomach muscles are inhibited, the abdominal wall is inhibited, we're not going to have a good pull and stiffening of that thoracolumbar fascia for load distribution from the latissimus to the gluteus and around. So that can greatly affect our trunk stability and our ability to really transfer loads well. We can have a loss of normal biomechanics for walking and other functional movement patterns, decreased transverse plane motion, and limitations of sagittal motions. One of the first things that we usually see that is lost in people as we age or they have surgeries and things like that is loss of rotation. There are a lot of tender points, trigger points as described by Travell, but I think we kind of have transferred into calling them tender points. And you can find these all along the side of the abdominal wall. You look at the bottom picture, there's some tender points that really occur down going where the descending colon is. And stool holding in that area can really affect and give us a lot of tender points into our abdominal wall.